Hello everyone, so welcome to today's video. So today's topic is on intravenous induction agents. So we're going to talk a little bit about the induction process as well as some of the drugs. Now anesthesia is a continuum, so it starts off with loss of consciousness, then recall, and then on the other end of the spectrum you lose all reflexes. Now, there are several phases of anesthesia. One is the analgesia phase, excitement, surgical anesthesia, and overdose. So, the plane you need to get your patient in is obviously surgical anesthesia. Okay, that's the desired plane. Now, in the induction process is the process where you transition from the awake to the anesthetized state. Now, this period, this induction, is a period of great physiological change for the patient, and they're prone to a lot of complications. It is a phase that is most difficult to tolerate in most patients. So the patients can develop hypotension, arrhythmias, they could stop breathing. Well, most of them would stop breathing. They can have aspiration because they lose the airway reflexes when they become unconscious. They can have forced closure of the glottis, that is a laryngospasm, adverse drug reactions, and you could develop involuntary movements. So induction could be either IV or inhalational. It's most commonly done via IV, although we do reserve inhalational for pediatric patients without IV accesses and in patients with difficult airways. So the commonly used IV induction agents are, first off, is propofol. More likely than not, you're going to only be seeing propofol use. And the reason for that is propofol is so vastly superior to all other agents, there is really no need for propofol, right? That is the superiority of propofol. Other agents are thiopental, which used to be used a couple of years ago. Really, I don't think anybody manufactures it again. The benzodiazepines and ketamine, and you also see a lot of ketamine being used. Now, how anesthesia induction started. So traditionally, people were induced by inhalational methods. So there was a special mask, or they used to put some chloroform in a cloth and give the patient that inhale. However, when the patient breathed in the agent, they passed through that excitement phase, that second phase of anesthesia. And this causes sometimes the patients to gag, to move, to cough. They could develop laryngospasm, and this is very unpleasant. But when we started using IV agents, we found that patients started moving very quickly to the phases and they achieved surgical anesthesia very quickly. Now, this is why it's one of the predominant form of anesthesia used today. Within the time you inject that syringe, more or less the patient has reached has been anesthetized, right, and will shortly after reach surgical anesthesia. But it's a phase not without complication. Hypotension is one of the significant complications of this phase. Okay, then you also have the patients developing apnea, so they stop breathing, and hypoxemia, lack of oxygen. Now, a little more history for you. For example, during the World War II, that's when pentothal, which is sodium thiopentone, which is an IV agent, first came into vogue, right? Now, there's this myth or urban legend that says pentothal killed more patients during the war than the Japanese, right? I don't know if that's true or not, but it just shows the lethality of these IV induction agents, especially if not used appropriately. And at this time, people did not have that skill in terms of the using of these agents. Now, just to talk a little bit briefly, terpentone has been used for many years, decades, okay? But it's no longer available. So you had to reconstitute it, you had to mix it, but it's a rapid induction again. And this was a great benefit. So within one arm brain circulation time, from the time it takes to reach your arm to your brain, it starts to work, and it could last for about 5 to 15 minutes. Again, you're going to become apneic, you're not going to stop breathing, and you're also going to lose your airway reflexes. And cardiovascularly, it can cause severe hypotension, especially in volume depleted or shock patients, as they would have learned during the war when these patients had massive blood loss. Brain-wise, it decreases your cerebral oxygen consumption and reduces your, and it can reduce your ICP and your cerebral blood flow, which is a significant benefit over the inhalational agents, especially in patients with traumatic brain injuries. So how does thiopental stop working? It stops working via redistribution, so it just redistributes away. But primarily, it leaves the body via metabolism, via the liver. Now, onto propofol, really the gold standard anesthetic agent. So the drug name is 2,6-diisopropylphenol, an excellent drug. And the reason why it's used so commonly now, it produces a rapid loss of consciousness. And this is a key distinguishing factor. Over the tapentone, you get a rapid, clear-headed recovery. So you go to sleep quick, you wake up fast, and you don't have any lag or hangover effect. And another advantage of propofol is that it effectively upturns your laryngeal reflexes without the need for muscle relaxant. So it makes it an excellent drug for inserting your supraglossic devices, which are the airway devices of choice nowadays for most surgeries. Again, like tapentone, propofol causes severe hypotension, right? In a shock patient, just a couple mils could cause a cardiovascular arrest. It's going to cause apnea, and the CNS effects are still like tapentone: reduce brain oxygen consumption, reduce ICP, and reduce cerebral blood flow. So other side effects of propofol is that pain and injection. It can be very uncomfortable for patients, right? So the termination effect of propofol is via redistribution, so it just dissolves away, but it is metabolized via the liver and other extrahepatic sites. Now on to your benzodiazepines. In the OR, you'll see midazolam being commonly used, and it's not an induction agent on its own, right? It's usually used for pre-medication, and it usually uses as an anxiolytic, and as an adjunct, it can reduce the dose, right? It acts at the GABA receptors in the CNS, and the GABA being inhibitory receptors. Now, midazolam is a short-acting benzodiazepine. Again, we tend to like to use short-acting drugs in the OR because we want our patients to be up and awake by the time we're ready for discharge. It can be given a range of routes. It can be given PO, it can be given IV, it can be given IM and intranasal. CVS, it causes a minor decrease in BP, and apnea could occur in higher doses, okay? But patients, it generally preserves respiration. CNS wise, it can cause hypnosis, it can cause sedation. Importantly, though, it generally tends to cause anterograde amnesia, which is amnesia for subsequent events that happens after you give the midazolam. So another benzodiazepine, just for the purpose of mentioning it, is Valium or diazepam. It's a longer acting benzodiazepine. Could also be given PO, IV, IM, and rectal. It's generally used for the termination of seizures. Some people still use it as anxiolytic, but we prefer the shorter acting agents like midazolam, or even um, stuff like alprazolam. So again, as with all the benzos, they have minimal cardiovascular effects and respiratory effects at normal dose, but it's a longer acting agent. Now, ketamine, you're going to see a lot of patients using, anesthesiologists using ketamine, right? Ketamine is a phencyclidine derivative, and it is a drug of abuse. It is the only induction agent that is also a potent analgesic. That is an important point to note, because propofol is not an analgesic, nor is thiopentone. And it causes a strange type of anesthesia. It's what we call dissociative anesthesia. So the patient appears awake, so they may be staring at you, but they have this intense analgesia. So although they're awake, they're not really feeling anything. So it maintains your blood pressure. It can even cause an increased heart rate and high blood pressure, right? So that's a good thing about it. And it causes minimum respiratory depression. The other thing to note about ketamine is a potent hallucinogenic agent. Okay, sometimes we pre-treat with a benzodiazepine, and it also causes a lot of salivation. So in a lot of countries where there are no anesthesiologists or not enough money to afford anesthetic agents, they use multiple doses of ketamine as the sole anesthetic. Now, you would rarely see ketamine being used as the sole anesthetic locally. It's more used for patients who are in shock, right? And again, people who don't have the funds to afford that. The reason being that ketamine is not going to give you as good an anesthetic agent as propofol, right? You're not going to get that. Patients going to be salivating. They're going to have these hallucinations. And it's also used as a sedative if you have a very aggressive and combative child. The reason being, you can give it and not really have to worry about if it causes any respiratory depression. It's used a lot in veterinary anesthesia. And one of the resurgence of ketamine, it's used in chronic and acute pain management. And most of the indications for ketamine that you're going to see is in this area. Okay, so thank you all very much for listening.